Hello, everyone. Also, thank you, Jess, for your wonderful presentation. I didn't say anything just in case people had questions, but it was awesome that we both presented today because they're on similar topics. So thank you. Um, Basically, my name is Miranda, and I'm presenting today on the use of cranial POCUS in a resource-limited setting for an emergent craniotomy, cadaveric procedural report. I initially dreamt up this project while applying to the Anatomy Fellowship in the fall of 2023, so I'm really excited to be able to finally share it with you all today. I have a lot to cover, so I'm going to be moving fast. Okay. So these are some phrases I'm going to be using throughout today's presentation, including cranial POCUS or C-POCUS, which is cranial ultrasound, EDH or epidural hematoma, TTW or transtemporal window, EZIO, which is just a type of interosseous needle, MMA for middle meningeal artery, and ICP for increased intracranial pressure. Epidural hematomas are uncommon but very serious. Without immediate decompression, an unstable epidural hematoma will lead to brain herniation and death. Indications for an unstable EDH are a fixed dilated pupil due to compression of the oculomotor nerve and possible uncal herniation, Cushing triad, which includes bradycardia, respiratory depression, and hypertension, transient loss of consciousness followed by a lucid interval, then further deterioration, and lastly, the patient will be in a coma or have a GCS of less than 9. The incidence of EDH is not known, but the occurrence is highest among adolescents and young adults. This is because the causes are most often from head trauma, including skull fractures, and commonly involve injury to the middle meningeal artery. The management for an unstable EDH is surgery by either placing burr holes or removing a piece of skull through a craniotomy in order to relieve ICP. The criteria for surgery includes focal neurological signs attributed to an acute EDH, a GCS less than 9, fixed dilated pupil, ipsilateral to the hematoma, hematoma volume of greater than 30 milliliters, which is evaluated by a CT, and hematoma growth causing ICP or neurological deterioration. So basically, we know now that unstable epidural hematomas are bad and require immediate intervention. These studies demonstrate the off-label use of interosseous needles in lieu of the traditional neurosurgical burr hole equipment. It is suggested that when neurosurgery is unavailable and transport time is greater than 90 minutes, decompressing the hematoma leads to decreased mortality and better outcomes prior to transport. Most often, the physicians performing the surgical procedure are not practiced in placing burr holes or lack the equipment in their emergency room in general. And it is recommended to complete the procedure. Additionally, it's recommended to complete this procedure under neurosurgical guidance via telehealth if possible. These physicians are typically more practiced in placing interosseous needles. Therefore, it is proposed to complete the burr hole surgery with an interosseous needle instead, and this may have increased patient safety and efficacy. There are 6 total case reports published concerning IO needle placement to decompress an epidural hematoma specifically, as well as 1 published case report of a newborn receiving ultrasound-guided needle decompression for an epidural hematoma. And there's also 2 published cadaveric reports concerning IO placement to evacuate an epidural hematoma. So let's transition to the idea of using a non-invasive, safe diagnostic tool in combination with an austere approach to surgical burr holes. Cranial POCUS is used to indirectly measure ICP as well as directly diagnose ICP through visualization of midline shift in practice in many ICUs additionally. The transcranial window, the transtemporal window is one of 4 acoustic windows used to view brain anatomy and pathology. The temporal bone is thin enough that ultrasound waves are able to pass through. This leads to our proposal of using cranial POCUS to guide the IO burr hole procedure. It's paramount to also mention that the gold standard for this procedure is to reference a CT scan prior to completing it, and also for this procedure to be performed by a neurosurgeon. However, it's not always feasible to complete this procedure according to the gold standard. When no CT is available and mortality is imminent, the current guidelines suggest exploratory burr holes by non-neurosurgeon physicians. Okay, so this is also a quote that I really liked from one of the research papers. When faced with a situation where mortality approaches 100%, a simple technique using the correct equipment can be robust, safe, and life-saving, even in the hands of non-specialists. And it really underlines the importance of continuous research related to this topic, as well as novel approaches. So, we are proposing that cranial POCUS is a safe, affordable alternative when no CT or neurosurgeon is available and high clinical suspicion of an unstable EDH. Additionally, we are proposing that an IO needle be used as an alternative to traditional neurosurgical tools for an emergency burr hole placed by a non-neurosurgeon physician. Following this, I will outline a procedural cadaveric report on using cranial POCUS in conjunction with an easy IO needle to drain a simulated epidural hematoma. Here is a list of our materials. For the sake of time, I will move on. So first, the butterflies preset should be set to cardiac when we are identifying the transcranial window, specifically the transtemporal window. Next, the temporal window was found contralateral to the fixed dilated pupil. This is because we want to view it contralaterally. You get a better image when basically the hematoma that you're trying to locate is at the bottom of your screen. Landmarks were identified primarily the bilateral temporal bones. By this, I mean when we are looking through that acoustic window, we are trying to find landmarks on the image to ensure that we are in the correct place. On a deceased individual or cadaver, it is most feasible to be looking for the bilateral temporal bones, as there is no brain activity. And also, this is really important to check prior to the procedure because the transtemporal window is not viewable in 5 to 30% of patients, according to previous literature. Next, we prepared the hematoma simulation. So I removed the calvarium, and the simulated hematoma or water balloon was inserted between the dura mater and temporal bone. And then the calvarium was then replaced and fixed with tape. Okay, and then now we are to the meat of the report. So the transtemporal window was then again obtained, and simulated hematoma was contralaterally visualized. The temporal burr hole location was identified by moving 2 finger breadths anterior to the external auditory canal and 2 finger breadths superior to the zygomatic arch, which is the typical placement of a temporal burr hole. The EZIO was then drilled and the hematoma was drained. Both a 25 millimeter and 15 millimeter needle were used. The skin was intact for the 25 millimeter needle, and the skin and tissue were reflected for the 15 millimeter needle. So here you can see the simulated epidural hematoma perimeter, which is right here. And this is the temporal bone. So this is the before picture, this is the after, and you can see that it is no longer there. And here is a video. You can see it drain. Additionally, I measured the left temporal region thickness with skin and tissue as well as without. The purpose of this was to confirm recommended needle length with previous studies. So again, when CT is available, it is the gold standard for patient care. However, we recommend the novel use of cranial POCUS to identify the presence of an epidural hematoma and monitor evacuation as a safe alternative when CT is unavailable. We also recommend its use clinically for measuring ACP midline shift and serial monitoring post-procedure. The measured temporal bone and skin/tissue thickness in this study was 13.25 millimeters, which left little room for error with a 15 millimeter needle in a potential patient with edema and other signs of trauma. So we recommend to use a 15 millimeter needle when the skin and tissue is dissected down to the bone, or a 25 millimeter needle if there's no incision or dissection. And this is basically what previous studies have proposed as well. There are several limitations in this study, including that a cadaveric brain is not an accurate imitation of the activity a live human brain would have. Which also makes certain structures difficult to find on cranial POCUS. The use of a water balloon is also vastly different than real human tissues, and this study was only completed with one cadaver. And lastly, I'm also just a medical student, not classically trained in cranial POCUS, so that adds another complexity and limitation. In conclusion, POCUS is a non-invasive portable imaging tool that is widely used to aid in diagnosing a variety of pathologies. While non-traditional methods to treat emergent intracranial hematomas have been reported, none have utilized cranial POCUS as an adjunctive modality for diagnosis and treatment in adults. Therefore, this cadaveric feasibility study demonstrated a novel approach to the diagnosis and management of emergent intracranial hematomas through the use of cranial POCUS. And those are my references. I want to just thank the donors that give to the KCU donor gift body program. None of this would be possible without them. And I also want to thank all of the other authors that helped me on this project. It has been 2 years, and fellows. It's been 2 years of me deciding on and off whether or not it was going to work, and I'm excited that it finally did.